And it gives me great pleasure to introduce the first one this year by Bhavnoor Pannu from the University of Toronto on dual scoping review of factors causing misdiagnosis of cardiovascular diseases in women. Welcome, Bhavnoor.
Thank you so much, everyone. It's an absolute honor being here. I'll quickly share my slides and we can get going. We've talked a lot about the science part of the 10th Annual Science and Society Conference, so I'll just bring everyone's focus on the society aspect of it while I talk about misdiagnosis. My research is a dual scoping review on the factors causing misdiagnosis of cardiovascular diseases in women. We will talk about what misdiagnosis is, why does it occur, the gaps in current literature, my methodology, and then the results in the discussion. So what is misdiagnosis? Misdiagnosis is a preventable medical error, and it can come in various forms. Underdiagnosis is where one group of people is disproportionately diagnosed less than the others, and this may be due to diagnostic errors, insensitivity of our methodology or our diagnostic procedures, but it can also arise from just medical practitioner prejudice. Undiagnosis and missed diagnosis is where a disease or disorder is completely missed in a population. And delayed diagnosis or untimely diagnosis can occur because of one or all of the aforementioned reasons. What is the state of the issue? It's actually quite terrible, unfortunately. In 2019, cardiovascular diseases accounted for 1/3 of all female deaths worldwide, and over 9 million women around the world live with some form of cardiovascular disorder or a risk factor. And if we combine all the loss of life, the loss of life lived with quality years, which is called a daily value or the disability adjusted life years value in public health, over 171 million years of all the women over the world combined are lost because of cardiovascular diseases. So, one, before coming to the hospital, women have a higher risk as compared to men of having cardiovascular diseases. But then they face a lot of access issues and barriers to arrive at the hospital. But even when they do, women are 25% more likely to be misdiagnosed following a stroke. And even when they are correctly diagnosed, over 50% women face a higher likelihood of being discharged very early post diagnosis, even with an unstable angina. And despite constantly seeking medical care for the same period as men, six out of the 11 gender non-specific cancers in the UK between the years of 2007 and 2010, it took women 30 more days than men to be correctly diagnosed. So at every level of diagnosis, women face multiple barriers which compound, leading to their bad health. But why does misdiagnosis occurs? Misdiagnosis is a manifestation of prejudices against the biological sex of women, of females, sorry, but at the same time their social gender identity of being a woman. Because of their biological sexual dimorphisms, women face atypical symptoms. Technically, these symptoms are not atypical. They are very typical to this exact population that we are ignoring, which is women. But these atypical symptoms are ignored in current research. Furthermore, in clinical practice, because of biases and prejudices, the social construct of women's genders act as a barrier, and structural and systemic factors exacerbate both of these existing issues. But why does it even matter? For over the years, women have faced way higher mortality than men for cardiovascular diseases, which in colloquial terms are mostly known as a man's disease. So, although 1 in 3 women succumb to these diseases, we are not paying attention. So, it's very much in need of the hour to focus scientific and clinical and policy research towards this issue. So, having all of that background, I was faced with a bunch of questions. The first one was, so we know the social factors that cause misdiagnosis, we know the biological factors that cause misdiagnosis. What are all the risk factors which we must include to correctly diagnose women? And once I collected all of them, the second question I had was, so from all of those risk factors and variables, what are we currently missing while researching and diagnosing women? And why did I use cardiovascular diseases? One, of course, they're very high health burden, where 1 in 3 women die of cardiovascular diseases. There is an existing extensive body of research, which I could very conveniently use for my dual scoping review. And there are also established biomarkers and diagnostic criteria for cardiovascular diseases. For my methodology, in part one, I established all of those variables. I answered the question number one, what are all the variables? And to compile that list, I collected all the primary and secondary research which identified the things we were missing. I took up all the clinical recommendations released by multiple global conglomerations of physicians that, okay, these are the variables that must be considered for accurately diagnosing women. I looked at all the biological factors, the new novel biomarkers that are coming up, and the different manifestations of sex hormones for accurate diagnostic criteria. And I also looked at the rehabilitation criteria for cardiovascular diseases to compile a comprehensive list of all the biological and the social gender risk factors which we must include to correctly diagnose women. So now that I had all of my variables established, I put that across current primary data. I took primary data from the last 5 years for cardiovascular diseases. I took all the different kinds of primary literature and analyzed them against the variables that I established in part one. So what were the results? These were the results. I cluster plotted all the variables against the primary papers. I was able to compile a list of 29 variables, 19 of which pertain to the biological sex of females, and 9 of which related to the social gender construct of them being a woman. And finally, one variable was the race of the individuals. These were all the primary literature that I collected from Scopus and PubMed, 57 primary articles, which were case reports, clinical trials, mathematical models, and a lot of observational studies as well. And I analyzed whether they included those variables which we must have included. Wherever you see a navy blue box, that indicates that that variable was considered. The yellow one was that it was considered at a very surface levels. The authors recognized that this variable is important to correctly diagnose women, but they did not use that variable and integrate into their methodology. The red ones were quite disappointing actually, where the authors recognized that these variables are important to correctly diagnose women, but they confounded the variables. They did not consider it at all. And as you can see from a distance from the cluster plot results, the white space is very disappointing that most of the variables are unfortunately not being considered, which must be considered to accurately diagnose women. For most of the biological sex factors like age, how much diagnostic variables were being considered, they had quite high coverage of around 85% of the primary articles considering those variables. But when you come to the social gender variables, it's even more sad, where the maximum number that you can get in one row was 17% coverage. If we combine all of the biological variables, only 30% of the biological variables were considered by the primary articles in the last 5 years, and only 7% of the social gender variables were considered by them. I looked at other characteristics of the primary articles that I collected, which showed primary papers from all over the world. And ischemic heart attack, which is considered a disease of the developed world, is impacting women more often than men. So this does not seem to be an issue of resources or infrastructure. It seems to be a very core research priority that we have got incorrectly. Furthermore, when we talk about the characteristics of the papers, mostly case reports were doing well on recognizing this nuanced intersectional issue which impacts the gender identity of women and the biological sex of females. So this really made me question about in research how we consider randomized control trials to be the gold standard for knowledge. But then when it comes to such nuanced issues, some of the lesser used or lesser funded as well kinds of primary research are doing better at considering those variables. Finally, although there does not seem to be a real pattern with the temporal publication of these papers, what was really concerning was the numbers. For cardiovascular research, we recognize thousands of papers are being published every single year, but only 9, 5, 13, 7, and so on papers per year, which are aware of misdiagnosis, was very scary indeed, how we are not prioritizing women's correct diagnosis at all. So why does this matter? This matters because women make up 50% of the population and they are meant to be protected by the infrastructures of coming to a hospital, accessing healthcare. And the same structures were supposed to protect women are failing them. But what actionable steps can we take? This is a call to all of the researchers out there that whenever you are designing your papers, you pay extra attention to include those variables and integrate them into the very core foundation of your methodology. This is a call to all of the policymakers that you must include policies for designing these research studies, which must include and make it mandatory for the research studies to include these variables. This is a call to all of the grant funders out there that in order to get funding for these methodologies, we make it mandatory to include these variables to ensure gold standard quality healthcare for women. These are just my abundant references, and thank you so much for your attention. And I also have an advocacy journey alongside my dual scoping review, so please feel free to follow any of my outlets here, and I'll be very glad to take any questions now.